We trained all of the staff up to do carers assessments and then care plan accordingly. And we also introduced carers clinics. And these carers clinics happened at different times of the week. So I would run one as a ward manager, but there'd also be other ones run by the clinical charge nurses and by primary nurses on the ward. We did a lot of work on the environment and making the environment a lot more homely and relaxing. And particularly work we did on the Family and Visitors Lounge, which was a protected area which was specifically just for families and visitors to come in and visit their relatives. And we revamped the children's visiting area as well. So relieving boredom, well, this is obviously a traditionally a timetable of activities run by the occupational therapist on the unit. This was ours, and this was displayed on our unit at the time. It's a very good activity programme. We had a brilliant occupational therapist on the ward. And what we wanted to do really was have the groups facilitated not only by occupational therapists, but also by nurses and by doctors. And we worked hard to co-produce this timetable with our patients on the unit and with other members of the team. And this is what we had. So we had a 7-day programme and at evenings as well. And it was really trying to convince staff that they had the capability to facilitate these things, but also the capacity to do it. Because people are just constantly busy. They don't feel like they can cram anything else into their day-to-day work. So off the scene there was a lot of support and a lot of visibility to try and get this happening in practice. But we put some tools in place to support staff, and this was one of them. So this was just some guidance for nurses, qualified nurses, around the types of things they could do on a one-to-one level or in a group, looking at things like assessments, involving care coordinators and involving carers, etc. We also implemented some support guidance for healthcare assistants on the unit, and this was really about the activities, many from star wards, and we wanted to give them some ideas about what they could do, but also give them what the therapeutic value of that intervention was, so that they could articulate when asked if, why are you doing this, why are you playing a game of Monopoly? It seems a fairly boring sort of activity, or not boring, but not very therapeutic. They could then articulate exactly what the therapeutic value was. And what we saw was actually that then translated to note writing, so it was evidence then in the events at the end of the shift. And just as a bit of a sort of aid as well, by each computer we had this, and this was all the groups that were available on the ward, and then we have the therapeutic aims of that group. So again, it's just to support staff to think about, when they write the notes, what was the therapeutic value of that. And we co-produced leaflets to sit alongside the interventions that we did, as well as the groups that we offered. And what we would do is, it was sort of like like an information care pathway, I suppose you could say. But from admission to discharge, you would give the information at different times. So you wouldn't just give them a bulk of information right when they're in the most ill part of their admission. You would wait and you would give different types of information as you progress through, and then they would attend the groups and have the different interventions at that time as well. Starting from basic information about the ward, moving right through to discharge, giving some information about what services are available in the community. So good night's sleep. Well, we were surprised to see some of the feedback come back from this. Lots of it were around problems with the environment, around smells and noises and bed comfort. But a lot about anxiety and fear about being in hospital, and particularly at night, the visibility of nurses in bedroom areas, etc. And we also seen, we did an audit of our medication and saw that we had a fair reliance on PRN medication being used at night. So as the first point of call, people were asking for medication. So what we did, we implemented an evening relaxation therapy group that was run either by the late shift or the night nurses. Implemented sleep hygiene groups, and for those patients who did have an issue around sleep, we done sleep rating scales on them and introduced night care plans, and then we introduced these sleep packs, which I'm very proud of. And the feedback we were getting from patients around this was very much about, it just felt special to be given something like a gift on admission that they could use. I was fortunate enough to do a Dragon's Den type pitch to the director of nursing and ask for some money to actually spread this across all our services, and I did get some money, so we saw some fab qualitative outcomes with these. So lastly, improving safety. As you all know, and I'm sure you've seen an increase in the incidence of diabetes coming through into our services. But what we also identified was there was a gap in knowledge and confidence around the management of people suffering from diabetes, type 1 and type 2. So we wanted to address that. And what we did, we collaborated with our acute services, and they supported us in delivering some training to staff around diabetes. And then we developed this protocol and algorithm to support staff with the care of people with type 1, type 2 diabetes, as well as people who are potentially at risk of diabetes as well. And this is actually being developed even further by our physical health nurse, and now it's rolled out across the whole organisation. And the other area we looked at was abscondence. This was one of our highest reported incidents. The ward that I was working on was situated right next to the hospital gates, and we had many absconds. And there was a really strong focus within the team to improve engagement and observation. So what we did was we implemented the anti-absconding intervention package, which is by City University. I'm sure you've all probably, most of you will have come across this. And it's by Professor Len Bowers et al. And what we saw was a 30% reduction on that ward at that time in AWOLs, but subsequent to that we've rolled that out to other parts of the service through productive mental health ward as well, and we've saw similar results from other areas. So that's giving you a sort of whistle-stop tour of some of the improvements that we made, but it didn't come without its challenges. And I think leadership and support at all levels is definitely one of the challenges, and it's not just leadership at a clinical level, it's leadership throughout. And just going back to the point that has been mentioned a few times around compassion, I think you can't have nurses delivering, or any healthcare worker delivering compassionate care without compassionate leadership. MPT engagement, yes, that's always a big issue. Getting the doctors on board and facilitating some of the groups and engaging in some of these changes was challenging at times, but we did succeed. Resistance to change, it's always going to be an issue. Capability capacity, coming back to that, I mean, that was one of the biggest to try and convince staff that they could do this and that they had the capacity to do it. And then with any change, sustaining the change and continuously improving it is going to be a challenge. But I think, coming back to leadership, it is the key to success. And it has to be leadership at a shift-by-shift level, ward leadership level, and then above. And I've just put the NHS leadership framework on the slide because I think it's a really useful resource. It does have on the website a number of self-assessment tools to support people to develop their leadership skills, and module-based sort of work that you could do as well. I'm aware that this is currently being developed further at the moment, so we'll see a new revamped NHS leadership framework in the future. But thank you for listening.